All right, let's talk a little bit about how to prepare patients for GI exams. And you can see that this preparation it can be fairly lengthy. So some of these instructions involve fasting for 24 hours and things like that. So these aren't really rapid fire things. These are more gradual things that kind of have to be staged out. So the objectives for today. So we want to be able to explain why we're doing this and to have a why that is easily translated into patient language, like going back to the critical thinking exercise, something that a patient like Mrs. Short would understand. So being able to explain it in a way that everyday people will get it. We need to be able to think about sequencing and scheduling. So that's what the types of patients, where they should fall on our schedule, how and why we do bowel prep, because it's one of those things that patients will complain a lot about, and so we need to be able to give them a good reason why we're doing all this uncomfortable stuff. Talking about things that will make barium a little bit more palatable or easy to do for patients. Think about how to administer different types of contrast, particularly when we're talking about enemas and things like that. Temperature does matter. We want to be able to position patients appropriately for the enema. We want to talk about contraindications for use of different types of contrast in different areas of the body. So whether it's what are contraindications and indications for upper GI, what's contraindications and indications for lower GI. We'll look at some pictures and talk about what those result in. And then the final things that kind of got cut off is we'll actually look at pictures of different types of disease and how they appear on the images. Key terms, they also got cut off, I'm sorry, but pretty much everything that's here listed in the chapter on page 305 is going to be important and helpful for us to understand. All right, so the first kind of critical thinking exercise here is thinking about the order in which things should be scheduled. Now, oftentimes at an outpatient facility, there's a policy in place, and the people working the front desk, the scheduling department, they kind of have this locked down, and they can be aware of who goes where and when. But if you're dealing with a patient coming down from inpatient from the floor, you may be required to make those considerations and make those calls. So it is important. The first thing that we should be doing is anything that does not require any kind of IV contrast or any kind of oral contrast, any kind of contrast at all. That would include things like ultrasounds, right? Nuke med studies. Those types of exams need to be done first. Then the lab needs to have their chance to do any kind of iodine uptake values. That's pretty much the only lab value that can be messed up by use of contrast. Then we'll do anything that is specifically for the urinary tract. Now these are pretty rare exams now. I don't think when I was in school they were still mandatory to do like an intravenous pyelogram, but they've pretty much been relegated to CT, right? But the idea being that the reason that we have urinary and biliary next is because those are IV contrast, and they could be easily obscured by barium in the colon. Barium's just thicker stuff. The colon's a bigger organ. So the last thing in our list is upper GI and lower GI stuff. All right. There's been some debate in the past about when exactly to do CTs. And whether or not CT influences things like nuclear medicine exams and things like that. Our textbook just notes that you can use IV contrast after blood has been drawn for iodine uptake. So I would just leave it at that. For the most part, if we're looking at our schedule, and I have seen this happen, where you've got a patient scheduled for a barium enema and they're also scheduled for a CT. Well, it's like, what's going on? And what can sometimes happen is you could have two different physicians ordering on that patient, like one specialist and another specialist ordering exams for that patient. If one of those specialists is kind of old school, they might have ordered that barium enema, right? And the more new school specialist ordered the CT. Both exams are diagnosing the exact same thing, so there's really no reason to be doing both. So be mindful of that, because chances are insurance will not reimburse for both. And also the patient doesn't need to endure all of that.
How do you know which one to pick?
Generally, the CT is the gold standard for a lot of stuff. That's not always the case, but often is. When we've got a patient that's slated for a bunch of different studies, we want to be mindful, even though sometimes our departments don't communicate the best, of if we've exceeded giving them too much IV contrast, iodine contrast. So that is something to bear in mind, that if they just had a CT this morning with IV contrast and they've ordered another for the afternoon, well, we probably need to check in with the radiologist and see if they want to change anything about the dosage of IV contrast. Do we want to give them less? Do we want to hydrate them before and after? Those types of care considerations we should be working with the physician to consider. And just because I know that things have changed a lot, I'll kind of get up on my soapbox for just a minute and talk about back when I was in X-ray, or back when I was in school. We still, the department just prior to me showing up had moved to digital. Prior to that, they had been a film-based department, and so they retained some of their film-based culture. So, for example, the radiologist reading room was right by the tech work area. The radiologist would frequently come out and say, hey, this is a really good picture, this picture looks like crap. And that was a big part of how we learned what we needed to learn as X-ray techs, was having that open communication, you know. The way that departments work now is, it feels more like Facebook. You could be friends with someone you've never met, right? How exciting is that? No, but what often is the case in our departments is you may be working with a physician and literally never see them, right? Which is weird, because in general, knowing human nature, if we have a relationship with someone that we never see, we assume that whatever they might be saying about us is what? Bad or mean, right? That's just human nature. So the same is true with a lot of tech relationships with the radiologists right now, and the same is true for a lot of radiologist relationships with ordering physicians, where in the past they would frequently communicate and be in the same room with each other. They're just not anymore. The digital thing's taken over, and the robots are going to shortly, feed us into the matrix and live off of our bodily fluids or something. So the reason I'm telling you all of that is, don't buy the lie. You can go and talk to the radiologist. There is a way to communicate appropriately with them. They expect it. They need it in order to have good patient care. You can talk to requesting physicians. Know what the heck you're saying. Don't waste their time, right? But they will appreciate that, and they will appreciate that you've kind of got their back in terms of making sure that patients are receiving appropriate care. Okay, making sure that folks are compliant is a whole branch of psychology at this point, and I've got it on a single PowerPoint slide here, right? But people do weird stuff. You ask them to do one thing and they do something totally different, right? And that's probably nowhere more evident than in people taking medications. One of the things that's interesting, there was a study that got released not long ago. They looked at people in their compliance with giving their pets medicine, right? And they had close to 100% compliance. So if you ask people to give their pets medicine, they'll do it, right? You ask them to give them their own frickin' selves medicine, they won't even get this prescription filled, right? Or if they do, they're not going to take it according to the list. So we are not the best at looking out for ourselves, right? For the most part, though, that's why we've got nurses on the inpatient side. They know that. Nurses get it. Patients are not compliant, right? And so we will coordinate with the nurses to make sure that patients are going to be compliant with any kind of preparation that needs to be done. Now, on the same time, looking on page 307, first paragraph on the left side, nurses usually learn about the rationale for examinations and the particulars of preparation on the job. What that says is there's not a nursing class here at Baptist or any other nursing school in the world that I've heard of where they learn about how x-ray exams work. They don't know the first thing about what we're doing. And I'm not saying that to be mean. They don't. They haven't been taught that. Where do they learn it? They learn it on the job. Who is going to teach them that? The answer should be this guy, right? You are the ones who are going to be teaching them that, right? So again, my instructions to you is know your stuff, right? And don't be a jerk about it, but let them know, okay, today we've got Miss Short scheduled for this exam. For this exam, we are using an IV contrast, which is iodine-based, and it does affect kidney function, right? We need to know a little bit about the patient's history, whether or not they're on metformin, because there's contraindications for that. So be able to speak nurse language to them, and you will be teaching them in a language they can understand and receive, right? I'm not saying talk down to them or anything like that. They're just as smart as you are about other stuff, right? Outpatients. This is the part where we do kind of need to talk down to people, right? We do have to put it down in people's everyday language, right? Tomorrow we're going to give you what we call contrast. It works kind of like a dye, and it colors your kidneys on the pictures so that we can more clearly see that and see if there's any disease there, right? So I will speak to the patient at about a 6th grade level of communication, right? And use language that will be really clear. I'm not trying to talk down to them, but I want to make sure that in the midst of their stress and their anxiety about this exam, that they're receiving what I'm telling them. A really good strategy is also to give them something in writing that explains what you're up to, because they can review it a later time. What did he say? They're giving me a dye. It's like food coloring. No, it's not food coloring. So reading over that, they might learn a little bit more about it. It may also be part of the history that you give those instructions as part of the patient history. And generally what we do in order to make sure that our patients were compliant, we do scout radiographs, and that lets us see whether or not they actually did what we asked them to do. I've got some examples of that in just a minute. All right, one last thing I'll say about giving instructions to patients. This is also on page 307. When we're scheduling or giving patient instructions over the phone or even face-to-face, it is important to have the patients repeat the instructions back to you in their own words, right? Not just to say, do you understand? Because they will say yes, and they don't understand, right? Ideally, as a teacher, I could do the exact same thing with each and every one of you. Like, not to put anyone on the spot, but Ms. Rojas, repeat to me everything that I just said about chapter 17 in this textbook, right? It would be wonderful, but that's not how education works. So that's why we have quizzes and tests like that. All right. Now, there are basically 4 things that we can use to prep the patient for the exam, and these are listed in order of their comfortability, with comfortability decreasing as we go down the list, right? So if you want to avoid awkward, painful situations, have a really good explanation of what their diet should be prior to the exam, right? Avoid the problem like what we had with Mrs. Short. This says that for barium studies, they should be fasting 24 hours before the exam, right? And restrict their diet to clear liquids. Clear liquids is a great rule of thumb. To avoid any food or drink that is not transparent.
Water.
water, juice, but not milk, because milk can solidify in digestion, right? Even to some degree, coffee is fine, although coffee can dehydrate people, right? But when we talk about NPO, I basically translate it to no food oral, don't eat anything. This is limited to about 8 to 12 hours. So we'll say after your dinner, don't eat anything else, right? You can take your medications as normal. Make sure you say that afterwards. You can take your medications as normal. But that fasting period can change. Now, there are things called cathartics, right? And they're about as fun as they sound like. It is not drum therapy. Drum therapy, I've heard, is a cathartic experience, like going and banging on drums in the park. That's not what I'm talking about. I'm talking about things ironically named stuff like Go Lightly, where you are going and there's nothing light about it, right? You will feel very light afterwards, right? That they use generally for preparation for things like a GI scope, right? So it just completely cleans you out like a demon inside of you or something. Suppositories, we mentioned these earlier. These are medications that are in like a semi-solid form. So be careful in handling them. Handle them with gloves, because they are basically ready to deliver the medication and they are inserted rectally. An example of things that can be used as both a suppository or a cleansing enema is any kind of soap, right? It irritates the bowel and will cause the bowels to empty, right? So back in the day, when my mom was a nurse, they literally used to give soap suppositories. They had small pieces of soap they would place in the rectum. It would stimulate the bowel, irritate the bowel, and the patient would evacuate their bowels. About as fun as it sounds. Cleansing enemas are a little bit more controlled, but even more uncomfortable for the patient. So we would place the patient in the Sims position that's indicated here on page 309. And we place an enema inside the patient, right? And we want the water to be at roughly the same temperature as their body, so it will be warmed up somewhat, right? Not hot, but warm. We would run that medication or that water into the bowel, right? So we'd have the bag hanging about a foot or so over the level of the rectum. And then once enough of the water has run into the medication has run into the large intestine, we would drop the bag down to the floor and evacuate the bowels into the bag. So that's why I say this is going from level of comfort to into the bag. You would not want it to go anywhere else, trust me. I have seen it go other places and it's not fun. So you may be asked to do some of these procedures, right? I'm not joking. These can be, we serve a therapeutic role for some of these types of things, and we have the camera that can see whether or not the bowels are empty, right? So since we've got that magical camera, we may be asked to do these types of things. Excessive pressure. So as we're cleansing the bowel, they can have spasms or cramps inside the bowel that makes it feel like they're fulled up. They want to evacuate their bowels right now. We need to be careful of excessive pressure, though. So stopping the flow of it, instructing the patient to try to relax, practice the breathing techniques or something. But we want to make sure we don't squeeze on the bag or anything like that. We're not trying to force this fluid into the colon, because there are conditions like diverticulitis or ulcerative colitis where we could risk a perforation to the bowel. The other thing that you should know before you start placing enema tips inside of anyone is some folks have got hemorrhoids, and it is pretty crazy looking. There's not really a medical way to put this other than like it's a sore right in the area of the rectum, and it is blood filled, right? So it is bright red. The book describes it as an enlarged rectal vein. So this can interfere with things like enema placement, right? And be aware of that. That some patients, especially older patients, may have that. It's nothing to be alarmed at. They're not giving birth to like a ghost baby or something like that. It is a hemorrhoid, all right? And then if they complain of feeling full, again, the breathing things is breathing or panting lightly. So that's the breathing instruction, right? I think it's called like the Valsalva maneuver or something like that. I don't know enough about that. All right, well, let's talk about, now that we've got the bowel prepped, where to go from here. Barium sulfate is your friend, right? Barium is it's actually right there on the periodic table. It is a fairly inert substance. It doesn't really react with anything. It doesn't like burst into flames or anything like that. Although, interestingly enough, it is what causes fireworks to be green. So the green fireworks, you can just imagine you're seeing barium enemas flying through the sky, right? We mix the powder with water, so we take that inert substance and we mix it with water, and that is literally what we are giving the patient. It is like drinking chalk, right? And they will say that this is like drinking chalk. And so the things that we can do to help with oral administration is to have it a little bit cool, so keep it in a refrigerator, and to use a straw, right? Not a paper straw, although I get why we're using those, but a good old plastic straw from the 1980s, and to drink it in that way, because it allows it to get past the mouth. If it's in the mouth, it basically turns to chalk inside your mouth, and it feels like you just emptied a box of Elmer's chalk or something into your mouth. So straw does help, and that's especially true if you're assisting a patient. And we always are interested in what the dilution is of it, because depending on the procedure, we will dilute it differently. So a paste form of it is just like it sounds. It's like peanut butter, chalk butter. And you can put it on a Ritz cracker, like a saltine cracker, and eat chalk on a cracker. You will ask some patients to do that for swallow studies, when we're evaluating how the epiglottis works and things like that within the oral pharynx. We can use it in a liquid form, and this can be either drunk or administered rectally, right? So sometimes that's pre-filled with a powder. We just add water, kind of warm water. Or sometimes we just have a already pre-diluted bottle of it that we empty into the bag, and we're good to go. We can also use iodinated media for a GI tract, right? Generally what we use is gastrographin, or just gastro. This is used when barium is contraindicated, when we should not be using barium, because the principal complicating agent of barium is this fancy word here at the bottom of 311. It is hygroscopic, right? That means it likes to absorb water, and it turns into plaster of Paris inside of you, right? That's what our textbook says. And this can result in an impaction, right? The other thing that we want to avoid with barium, and avoid it like the plague, is if there's any perforation suspected, of the large intestines especially, we would want to avoid the use of barium, because now we would have barium leaking out into the peritoneum. The peritoneum is basically this garbage bag filled with guts that each one of us has inside of us, right? So it's leaking out into the garbage bag. You've got plaster now inside of the garbage bag. It will be impossible to get that out. Impossible. And it will result in what we call barium peritonitis, which is possibly even fatal, right? So avoid using it with any suspicion of perforation, right? or in the case of a high risk for barium impaction, like with neonates. So those are the things we want to be careful with barium. The final thing with barium, and sometimes we don't think about this enough, especially in CT, is if they have an impending abdominal surgery. And a great case for that would be acute appendicitis. So generally, if we suspect appendicitis, patients admitted to the ER, we need to do a CT scan or an ultrasound or whatever. If we do the CT route, we want to avoid barium. Why? Because if they got appendicitis, they're going to surgery. Stat. We don't want to have to sit around and wait for them to evacuate their bowels of all the barium in order to go to surgery, right? The problem with that is it can be very difficult to visualize the appendix without the barium, which is a lot of times the case in a lot of what we do. Kind of fighting what we can see versus the way we're going to see it. All right. Risks related to iodinated contrast media like the gastrographin, the oral contrast medias, is severe dehydration. So if the gastrographin, when it gets into the large bowel, it starts to, again, dehydrate the patient. And aspiration. If you aspirate, honestly, gastrographin or barium, you're going to wind up with a really pretty study of all of the bronchioles in the lungs, right? Because they would have aspirated contrast into the major bronchus of the lungs, and it will never get out of the lungs, basically. Not be a good thing. That's why it's also contraindicated for esophageal study when fistula is suspected, because the fistula in the esophagus means that the esophagus communicates with the trachea. So this would just be another way of aspirating into the trachea a contrast media which is now in the lungs. Tracking with me? We will use it if it's a fistula, maybe like a urinary fistula or something like that. So fistula, again, is just an abnormal passageway between two pieces of the body, like in this case between the esophagus and the trachea. All right, air contrast. When we use air contrast for bowels, right, there's two ways that might be done. If it's an upper GI study, it's what they're talking about when they talk about, did you give the patient the fizzies? What are the fizzies? Well, they're like pop rocks for your stomach. And they go into your stomach and they fizz, literally, like the old Alka-Seltzer commercial. And it causes the expansion of carbon dioxide in your stomach, right? Which is where we would want negative contrast. So it's going to fill the stomach now with carbon dioxide, which shows up black on our picture. So that's a use of air or carbon dioxide contrast on the upper GI, esophagus and stomach area. If we are going to give it for the lower GI, large bowel, we're talking about double contrast studies for the bowel. We literally are going to inject air or carbon dioxide directly into the patient's bowel via the rectal tip, right? So we'll have a dual contrast enema tip where we can basically inflate the patient's bowels like a bicycle tire with a bicycle pump. I don't know how else to explain it. We do like glucagon. It's one of those drugs that we just kind of threw in there just to be weird. But it relaxes the GI tract, slows peristalsis, and reduces cramps. Initially, though, the drug was used to treat hypoglycemia, so we're not using it the right way. But it does these other things too. So a lot of times it's given intramuscularly to help with cramping prior to giving a barium enema. Oh, this is a terrible slide. But this just illustrates how much might be given and how long it will do that. I wouldn't worry about it, in all honesty. If you are at a facility that's regularly giving glucagon, they will have some kind of procedure to follow, and I would just follow their procedure. All right, let's talk about routine upper GI series, because chances are some of us, our first day in clinic, will be doing some of these things, right? These are using a fluoroscope. So a special x-ray table that has a video camera built into it to examine the esophagus, stomach, and duodenum, right? So how food is moving through the esophagus, stomach, and duodenum. You may even have some swallow studies where you're just looking at how the patients swallow. These are generally done for patients if they've had a stroke or something like that and they've lost some of their ability to swallow. What are your roles? Well, you need to be providing the patient with instructions, so listen closely to how the x-ray tech is giving those instructions. You'll take the patient's history, particularly their allergy history, diabetes, things like that. You'll get that scout radiograph, which we'll look at in just a minute. Then you will be working with the patient in terms of managing the cup of barium, right? That's really your job from then on out, is being the cup of barium holder. You're the cup bearer, right? And so your job is just to make sure the cup doesn't get spilled at that point. Here's a picture of what we're talking about. So this is a picture of a patient's stomach from an upper GI study, right? So a way to remember how your stomach's situated in the body is called the left hand rule. You can hold your left hand up like this, and it tells you, if you kind of tilt your head, the fingers back just a little bit, it lets you know how your stomach is situated in the side of your body, right? So you have the fundus, which is this upper portion. In this case, you can see it's showing up with some black air inside of it, and then you have the body, right? So you have the lesser curvature, the greater curvature, and then the area of the pylorus and the duodenum, right? So what's nice about this left-hand rule is it lets me know as I rotate the patient in different directions or have them seated up or laying supine or prone where the barium might be, where the air might be. So you can use it as, if you wind up in these studies, remember that left-hand rule, and it will help you understand why they're moving the patient in different directions. Because that's kind of the name of the game with these studies. We may do a double contrast. That again is when they say give them the fizzies, right? In addition to drinking barium, and it allows the patient to fill up with carbon dioxide. Now you'll notice, like Shrek would say, better out than in, right? This will cause the patient to burp a lot. That's okay. It's like that part in Charlie and the Chocolate Factory, right? Burping will help you move away from that ceiling fan. You should have never drank that stuff, Charlie. Okay. All right. Here again is a double contrast upper GI image. How is the patient laying? How is the patient situated for this study? Are they upright? Are they on their side? They're not upright. That's a great guess, though. Possibly Trendelenburg, or probably just supine, right? Probably just supine. Because again, to do the left-hand rule right, your fingers have to be angled back just a little bit. So if I'm laying supine, the air will be in the fundus, the barium will be in the fundus, and the air will be in the pylorus of the stomach. So it's just a little imagination game that you have to play to think about it. And I promise you'll get lots of chances to play this game. Okay, I don't even know what this is, and I'm just going to skip right past it because I've never done it, and it's just one of those funny things that, like, I think they threw in there just to make themselves look smart. So don't worry about that one. All right, small bowel stuff. These are weird exams, so we're going to have the patient drink some barium, and then they just walk around in a hospital gown for like 2 hours. Right? They just kind of wander the earth. And you'll see these people just kind of wandering the earth in the department and like trying to fight right and wrong or something. Now, I'm not joking. That's what happens in these studies. You get your first radiograph after 15 minutes, and then every 15 minutes after that, you just get another picture. So it's like you have this person who's just wandering the earth in the department. And occasionally, like, you'll do something in the ER, and you'll be like, oh crap, Miss Short's wandering the earth in the department. You'll go back and you'll get Miss Short's 30-minute picture, and you'll go do something else, maybe get some lunch, and then come back and grab Mrs. Short for her 45-minute picture, and you label each picture at the different times. Once the exam gets once the barium gets to the ileocecal valve, so that communication between the small bowel and the large intestine, the ileocecal valve, then you'll get the patient on the fluoro table, and the radiologist will take some additional pictures if he needs to, if it's not visualized on that final image. So here's an example of that small bowel image. 30 minutes post-ingestion. We've got barium in the stomach, right? So this was taken upright. We can see it draining into the duodenum and moving through parts of the ileum and jejunum. And by the way, no one can tell what parts of the small bowel are what, right? So don't be worried about that, right? The important thing is just that it's moving through there and that I don't see any of it in the large intestine. Enterocolitis. We're going to do this basically, we're going to do basically the exact same thing, but we're going to pass a tube through the patient's nose, past the stomach into the duodenum, and we're going to inject generally a water-soluble contrast or barium through a syringe through that tube. It is basically a small bowel follow-through through the patient's nose. We just want to be creative, I think. So, exact same picture. All right, the lower bowel. So you'll notice we kind of think about it as two different parts of the bowel in X-ray world. You've got the upper bowel, which we are accessing most of the times through the mouth or through the nose occasionally, but most of the times through the mouth. And then we've got the lower bowel, which we are going to be accessing through the rectum, right? For whatever reason. Sometimes it has to do with the disease processes that are there. Sometimes it's other stuff. But we kind of separate the bowel into two different things. So prior to starting this, we are going to take a scout image and see, did the patient follow the prep instructions? And then we get them ready for the enema placement. And once the enema is in place, generally what we do is we get the radiologist, they'll put the patient through a series of exercises with an enema tip inside their rectum, and then you'll remove the enema tip, have the patient evacuate their bowels into the toilet, and take a series of more pictures. It's fun for everyone. So here's those scout images, and we can see immediately, you lie. You were eating all sorts of food yesterday. So what am I looking at here? Well, this image on the left, I'll turn the lights down. I can't see any food or what we call future farts inside the patient, right? I just see the psoas muscles, and this person does not have any granola bars or anything. There's that one potential fart, and that's it, right? Over here, there's farts everywhere. You see them all? And between all of these farts, there's like, I always think about it as being granola. But there's stuff in there where they've been eating corn chips or something, and it's all stuck inside their large intestine, right? So they did not follow the prep instructions. They fail. You do get really pretty pictures, so you can comfort the patient with that. You're going to go through hell, but the pictures will be beautiful. So this is what a barium enema will look like. You'll notice there is no contrast in the small bowel or in the stomach. Why? Because we accessed it through the rectum. So we were able to pump their large intestine full of barium. Job well done. All right, when inserting an enema tip, if you want an example of what these things look like, it's on page 321 in the textbook. There's different types. You'll see there's a pediatric one on the upper picture. There's the most common one that I've used is there in the middle, And then there's like the economy grade one, right, that no one would want. You are typically the person responsible for it. Why? Because crap rolls downhill, y'all. If you haven't figured that out, that's kind of the theme of this discussion today. And you are at the bottom of the totem pole. So, well, actually, you're not quite there yet. The patient's at the bottom of the totem pole, but on this one at least. So you will place the enema tip, and then you may or may not be responsible for the inflation of it if it has an inflation cuff on it. The one in the middle here, this guy has an inflation cuff, and you can see what it looks like inflated. I'll turn the lights up so you can see it. And the idea with that is once you're past the opening of the anus and into the rectum, right? So once you get past the opening of the anus into the rectum, you inflate that tip and it will stay there. And trust me, you want it to stay there. Really, really bad. I can tell you war stories about times when it did not stay there. And it is some next level stuff, right? Because what we're talking about now is bowel contents under pressure, right, being released all at once, like a poop shotgun is what I'm talking about. So you want that thing to stay there. Why am I stressing that? You have to get it past the anus, right, past that initial sphincter into the rectum and then insert it so it's anchored against the anus, right? So I don't know how else to say this. This is coming from experience, right? Have the patient in the Sims position, and this does not indicate, well, yeah, it does, thank goodness. Wear gloves and lubricate that thing, right? And instruct them to breathe in that crazy breathing way. The best thing that you can do is be as professional as possible in your exercise of this and avoid eye contact at all times. All right. Once you've got it into the anus, and I wouldn't worry about the direction of it, do note this, right? This has happened to patients here in our program, right? And doing a general survey of the class, you would think we would know better, right? But yes. If there's any resistance felt, do not exert more force. I think that's kind of, I love that there's the exclamation point on that. Question who did this slide. Like we needed an illustration, here it is. All right, things we want to watch out for. Megacolon. Any perforation of the colon, and this is really obvious, but if they have an ostomy, you will not be accessing through the rectum, right? You'll access through the ostomy. And generally it will be a physician that will do that access at that point. All right, like I mentioned, we can also instill air through these. And that's, again, fun for everyone. The barium is going to be thicker on a single contrast study. It will just be a barium-coated bowel. In general, though, we like to instill air because it will allow for more even coating of the bowel, and we can see things like polyps more clearly sometimes if there's negative contrast there. So it can provide better visualization of the mucosal lining. Let me see if I have an example of that here. Yeah, this is a really pretty double contrast study on page 327. And I don't know, if I didn't know what this was, like if I was just in an art museum and I saw that, I would think that's some pretty cool art, right? That is interesting, the dual contrast study. So there's an example of what we're talking about. Okay, I think this was included just for fun, right? These did exist when I was still in school. There was one hospital in Utah that was still doing this, and it was kind of a running joke. But this study is insane, y'all. What you've got is a special toilet that you can put on top of the fluoro table, and you can film the patient while they poop. I don't know how else to say it. Like it's like James Brown's dream job or something. So I don't know why they were doing this, but there was ostensibly some kind of scientific reason for it. But that is what we had when we talked about the deficogram. They used a high-density barium paste. I think it's just included here as a like, wow, what have I gotten myself into type. You can be glad. Anytime you're like, oh my goodness, I'm so sick of doing barium enemas, you can just remind yourself, well, at least I'm not at LDS Hospital in Salt Lake, Utah doing deficograms all day long. That's what I used to tell myself. All right. As you can imagine, once you've done all these wonderful things to a person, there will need to be some follow-up, right? You'll need to make sure that they're doing okay, that they understand their instructions for how to get rid of all this barium that you've placed inside of them. Generally, the best thing you can tell people is drink a lot of water. And the next best thing is you can tell them is it goes in white and it comes out white. So if you're pooping white for the next week or so, it's okay. It's all right. You're among friends. The nursing staff may be the one administering that, and the nursing staff probably needs to know that they are going to be pooping like Casper ghosts for the next week or so, right? Let the nurses know that as well, right? If they're going home to a spouse or a loved one, you may need to explain that to them as well, although I can't really imagine how that conversation would go. Maybe provide them with some written instructions at that point. All right, thank y'all.